Hello, in this video, we're going to talk about antihypertensives, so medication to lower blood pressure. So the heart pumps oxygenated blood around our body. The heart first pumps this blood through the arteries, and this is in red here. And then once the oxygenated blood is distributed around the body tissues, the blood is then brought back to the heart via the veins here in blue. Focusing first on the heart actually pumps a certain amount of blood each time it contracts. And this is the cardiac output. The cardiac output allows blood to flow through the arteries and deliver oxygenated blood to tissues before returning back to the heart via the veins. The cardiac output itself has a big impact on blood pressure. Other organs responsible for or plays a role in regulating blood pressure include the liver, lungs, kidneys, and the endocrine organ above the kidneys called the adrenal glands. When we talk about blood pressure, we are really talking about the arterial blood pressure, so the mean arterial pressure. And this mean arterial pressure can be calculated by having cardiac output multiplied by the total peripheral resistance, TPR. And TPR is the resistance of the vessels of the artery in this case. To make things even more complicated, the blood pressure we know has two numbers, one on top called the systolic and one number on the bottom called the diastolic blood pressure. The systolic blood pressure is essentially the pressure of the arteries when the heart is pumping blood out. And the diastolic blood pressure is the pressure in the arteries when the heart is filling back with blood. Normal blood pressure is about 120/80. Hypertension means high blood pressure. Many things can cause hypertension. Persistent, untreated, or unmanaged hypertension can have serious consequences. And one way to treat hypertension is by using antihypertensives or medication to treat hypertension. And these medications can be remembered by the alphabet, so A, B, C, D, and E. Let's begin by looking at A. So A includes ACE inhibitors, angiotensin receptor blockers, and alpha-1 receptor blockers. Now, before focusing on these, let's just recap some physiology. So the liver produces this molecule called angiotensinogen. When there's a decrease in blood pressure in the arteries, the kidneys will detect this and then produce a molecule called renin. Now, renin enters circulation and is responsible for converting angiotensinogen produced by the liver into angiotensin 1. Angiotensin 1 will then circulate around the body and get in contact with a membrane-bound enzyme called ACE, or angiotensin converting enzyme, which mainly resides in the lung tissues. So ACE converts angiotensin 1 to angiotensin 2. Angiotensin 2 is an important regulator of blood pressure. And what it does is basically it increases blood pressure via a number of mechanisms. Angiotensin 2 binds onto angiotensin 2 receptors on many different types of cells around our body. And depending on what cell angiotensin binds to, its effect on the body differs. But essentially, it will result in an increase in blood pressure. So, for example, some of the effects of angiotensin 2 includes increasing sympathetic activity, vasoconstriction, stimulating the release of aldosterone, a hormone from the adrenal cortex. And these effects, all of them, will lead to an increase in blood pressure. ACE inhibitors, or angiotensin converting enzyme inhibitors, is a very common antihypertensive. These medications can be remembered by the ending pril. So for example, captopril, ramipril, they all end in prils usually. The mechanism of action of ACE inhibitor is that it inhibits ACE, the membrane-bound enzyme. And so it inhibits the conversion of angiotensin 1 to angiotensin 2. And because you have less angiotensin 2, means that you will decrease blood pressure because it's not working. Some side effects of ACE inhibitors include a dry cough, a rash, nausea, vomiting, diarrhea, angioedema, and headache. There are contraindications to using ACE inhibitors, or relative or absolute, and these include being pregnant, having bad asthma, chronic cough, being allergic to ACE inhibitors, having a kidney disease, particularly renal stenosis. The other medication that starts with A is the angiotensin receptor blocker. And as the name suggests, the mechanism of action, it blocks the binding of angiotensin 2 to its receptor. And so thus it will decrease the activity of angiotensin 2, which will result in a decrease in blood pressure. The side effects of angiotensin receptor blockers include headache, nausea, diarrhea, dizziness, and back pain. Some contraindications include pregnancy, renal stenosis bilaterally, and if they are allergic to angiotensin receptor blockers. It's interesting to note that angiotensin receptor blockers are usually used as an alternative to ACE inhibitors because people that use ACE inhibitors getting a dry cough is quite common, and so sometimes people change to the angiotensin receptor blockers. Angiotensin receptor blockers can be remembered because it usually ends in sartan. So for example, losartan, the sartans. Anyway, the final antihypertensives that begin with A are the alpha-1 receptor blockers. And these guys aim is to work on the vessel epithelial cells. So zooming into the blood vessels, here is the lumen of the blood vessel, and surrounding the lumen is the endothelial cells and the smooth muscle cells. The smooth muscle cells can contract usually, and this will make the lumen of the vessel smaller. Or the smooth muscle cells can relax, and this will dilate the lumen, making it wider. So as you might suspect, when the smooth muscle cells contract and the lumen becomes smaller, the blood pressure increases. The smooth muscle cells that surround the vessels have alpha-1 receptors. These receptors react to adrenaline produced by the nerve fibers or from adrenaline in circulation. Noradrenaline and adrenaline is same thing as epinephrine, norepinephrine. Anyway, noradrenaline can bind to the alpha-1 receptor, and this will cause or stimulate contraction of the smooth muscle cells. The contraction of the smooth muscle cells that surround the vessel will cause the vessel to become more smaller, will narrow the lumen, and this will lead to an increase in blood pressure. Alpha-1 receptor blockers, they block alpha-1 receptors, and thus the mechanism of action of alpha-1 receptor is that it inhibits the adrenergic activity, leading to the decrease in blood pressure. Alpha-1 receptor blockers also have a role in decreasing total cholesterol in the body. Thus, it's a good option for people who have both high blood pressure and cholesterol problems. Side effects include it can lead to hypotension, so a drastic decrease in blood pressure. So they were the antihypertensives that begin with A. Let's look at the antihypertensives that begin with B. B, it's easy, it's just beta blockers. And beta blockers are very easy to remember because they end usually in olol, like metoprolol and labetalol or lolololol. Anyway, beta blockers block what are called beta receptors. And beta receptors are important in the sympathetic activity. So by blocking the beta receptors, you are blocking sympathetic activity essentially. So there are beta receptors everywhere in the body. We will mainly concentrate on the heart here. So beta blockers can be selective and work specifically on the heart, or beta blockers can be non-selective and work on the periphery too, such as the blood vessels. But let's focus on the heart. The heart have these cells called pacemaker cells, which make up the conduction system of the heart. The pacemaker cells regulate the heart rate, so how fast your heart is pumping. The pacemaker cells can be influenced by many things, including the parasympathetic nervous system and the sympathetic nervous system. Pacemaker cells of the heart, they have receptors on them, the beta-1 receptors. Adrenergic neurons, which are part of the sympathetic nervous system, target these pacemaker cells and release adrenaline and noradrenaline, which will bind onto these beta-1 receptors. Thus, it will stimulate the pacemaker cells to fire more rapidly, which will increase the heart rate. And because you get an increase in heart rate, you will get an increase in blood pressure by increasing the cardiac output. Further, the heart itself is a muscular organ. They are made up of cardiomyocytes, which are basically the cardiac muscle cells. The muscle cells of the heart, the cardiomyocytes, are the cells which contract and help eject blood out. The heart muscle cells also contain beta-1 receptors. So noradrenaline and adrenaline released by adrenergic cells, the sympathetic nervous system, can stimulate the beta-1 receptors of the cardiac muscle cells, which will cause the cardiac muscle cells to contract stronger. And to be exact, it will lead to a more powerful contraction. With a more powerful contraction, the heart is able to increase cardiac output. And because you're increasing cardiac output, you will increase blood pressure. Beta blockers selective for the heart work by inhibiting beta-1 receptors. The mechanism of action of beta blockers is that they block the sympathetic function on the heart by blocking the beta-1 receptors. And they do this by two ways. First, by decreasing the heart rate, which will decrease cardiac output and then decrease blood pressure. Or they will decrease the myocardial contraction, the strength, and thus decreasing cardiac output, which will subsequently decrease blood pressure. Side effects of beta blockers include bradycardia, fatigue, hypotension, decrease in libido, impotence, and bronchoconstriction. Contraindications include obstructive lung disease and peripheral vascular disease. So that was the antihypertensives with B. Let's look at C antihypertensives. And the C's are the calcium channel blockers. Most names for calcium channel blockers, they end in or sound something like dapine or like mil. So for example, verapamil. But these guys are kind of hard to remember, but hopefully you get the idea. Anyway, in order to understand calcium channel blockers, we need to understand calcium and its role in the body. When you think of calcium, think of muscle contraction. Think of excitability. Calcium channels are important channels in our body that allow the movement of calcium in and out of cells or cellular organelles. There are two main calcium channels we will talk about, and these are the T-type calcium channels and the L-type calcium channels. But what these drugs do is that, as the name suggests, they block calcium channels. More specifically, they block T-type calcium channels and or L-type calcium channels. So there are L-type calcium channel blockers or T-type calcium channel blockers or both. And it's important to know this because these channels are found in different parts of our body. For example, in the heart, going back to our pacemaker cells, which control the heart rate, there are T-type calcium channels. Calcium activity in the pacemaker cells causes the heart to pump faster and so contributes to increasing the blood pressure. Think of T-type calcium channels as time, so T for time, because the pacemaker cells of the heart control the heart time, the heart rate. And so by using the T-type calcium channel blockers, it will block calcium activity and thus decrease heart rate, decreasing cardiac output, and then decreasing blood pressure. This might get confusing, but there are three types of T-type calcium channel blockers. These are the phenylalkylanes, such as verapamil, the benzothiazepines, such as diltiazem, and the dihydropyridines, such as the ones that end in dapine. So they are all different, but to put it simply, they just work differently, and they also work on L-type calcium channels. But anyway, so for example, here is verapamil, a common calcium channel blocker, which will block the T-type calcium channels of the pacemaker cells. Let's talk about the L-type calcium channels, which are found on smooth muscle cells. So here we have the blood vessel, which, as we know, contains smooth muscles. Here is the lumen of the vessel, for example. The L-type calcium channels allow influx of calcium into the muscle filaments, which will cause contraction. This will increase the blood pressure because it causes the vessels to contract and become more narrow. But the L-type calcium channels are also found in the cardiomyocytes, and thus they will increase the power of contraction of the cardiomyocytes, which will further increase cardiac output and so blood pressure. L-type calcium channel blockers are the dihydropyridines that end in dapine. Some of the drugs from dihydropyridine also block T-type calcium channels, and so is also part of the T-type calcium channel category. A common example of a L-type calcium channel blocker is nifedipine. Side effects of the dihydropyridines, like a lot of antihypertensives, are flushing, headache, dizziness from hypotension, palpitations, and peripheral edema. Contraindications of calcium channel blockers are congestive heart failure, heart block, hypotension, and ventricular tachycardia. And this is unique to calcium channel blockers because in heart failure, the heart is trying to compensate by contracting a lot harder. And so if you use a calcium channel blocker, specifically an L-type calcium channel blocker, you are weakening or you are reducing the strength of contraction of the heart. And this is what you do not want to do in people who have heart failure. So that was the C antihypertensive medication, the calcium channel blockers. Next is D for diuretics. So when we think of diuretics, we think of the kidneys. Diuretics works on the kidneys, and what they essentially do is induce diuresis, cause peeing. So when we pee, the water in our body, it drops, and this will then drop blood pressure. So here is the kidneys with the adrenal glands above it. And the functional unit of the kidneys, or the main players of the kidneys, are these things called nephrons. And there are millions of nephrons in the kidneys. And this is where diuretics work. It is important to understand that the nephron, the functional unit of the kidneys, they filter things from blood, and they allow for secretion and reabsorption of things in and out of the blood vessel. So here I'm just going to draw a vessel, a vein, let's just say, a vessel. And so the mechanism of action of diuretics, again, is to increase urine output, decrease fluid overload, and this will decrease blood pressure. And there are three types of diuretics, three main ones. These are the loop diuretics, which is the strongest of the lot, the thiazide diuretics, and the potassium-sparing diuretics. The nephron is divided into different sections, one of which is the loop of Henle. In the loop of Henle, in the ascending part, there is this channel, a symptomer, which transports one sodium molecule, two chloride molecules, and one potassium from the nephron back into circulation, back into the blood vessel. When sodium is reabsorbed in the blood, water follows. Loop diuretics inhibit the transport this transporter by inhibiting the movement of chloride ions, which will disrupt the whole transport. And so you don't get sodium moving into the blood vessel, and so you don't get water following, and so you don't get an increase in blood pressure. Thiazide diuretics work on the distal part of the nephron. There is a transporter here which reabsorbs sodium and chloride together. This will then draw water back into the blood as well, which will increase the blood pressure in the body. Thiazide diuretics block this transporter, and so block sodium reabsorption and thus water reabsorption, causing a decrease in blood pressure. In the distal part of the nephron, there's also this other transporter exchanger, which reabsorbs sodium but secretes potassium. And potassium-sparing diuretics inhibit this transporter. And by inhibiting this transporter, you actually decrease the reabsorption of sodium, which means you decrease the reabsorption of water, which subsequently decreases blood pressure. But you also prevent the secretion of potassium. And this is why it is called a potassium-sparing diuretic, because you're sparing potassium. And so all these diuretics, they essentially inhibit sodium from going into the blood, and so you have more sodium being peed out, which means that you have more water being peed out, which means that you will decrease blood pressure. Side effects of loop diuretics and thiazide diuretics include hypokalemia, hyponatremia, hypovolemia, hypotension, hyperuricemia, which increases the risk of gout, hyperglycemia, hypercalcemia, metabolic alkalosis, and pancreatitis. The side effects of potassium-sparing diuretics is quite different in that they can cause hyperkalemia, metabolic acidosis, and gynecomastia. If you want to know more about diuretics, I have a separate video on the pharmacology of diuretics. Finally, E, antihypertensives, is for endothelin receptor antagonists. And these guys basically relax the blood vessel, causing vasodilation, which will cause a decrease in blood pressure. They work on the blood vessel. The smooth muscle cells contain endothelin 1 receptors, which when endothelin, a molecule produced by the blood vessel itself, binds onto it, it will cause contraction and narrowing of the blood vessel, which will cause an increase in blood pressure, of course. Well, endothelin receptor antagonists, as the name suggests, inhibits this receptor, which means you don't get contraction of the vessel, which means that you will lower the blood pressure. The side effects of endothelin receptor antagonists include headache, peripheral edema, nasal congestion, nausea, hypotension, and palpitations. So that concludes the video on the antihypertensive medications. We looked at A, B, C, D, and E. A for ACE inhibitors, angiotensin receptor blockers, and alpha-1 alpha receptor antagonists. And we also looked at B for beta blockers, C for calcium channel blockers, D for diuretics, and finally we just looked at E for endothelin receptor antagonists. Anyway, I hope you enjoyed this video. I hope it was helpful. Thank you for watching. Bye.